Good morning, everyone, and thank you for joining our grand rounds this morning. With all the advances and innovations in structural heart disease interventions, we'd like to share some structural heart disease cases and have a heart team discussion regarding the management. To keep this interactive, please feel free to join by sending your questions to pollev.com, enter DeBakey, or text your questions to 37607 by texting in the word DeBakey. I'd like to start by introducing our presenters, Dr. Tanush Gupta, our Interventional Structural Heart Disease Fellow, and Dr. Payam Pournazari, our Advanced Cardiovascular Imaging Fellow. Joining me live today in the studio is Dr. Sachin Goel, who is the Houston Methodist Hospital Medical Director for Structural Heart Disease, and joining us virtually are Professor Dr. Mike Reardon, Professor of Cardiovascular Surgery, Dr. Neal Kleiman, Professor of Cardiology, and Dr. Stephen Little, Professor of Cardiology. We're going to start with the first case with Dr. Tanush Gupta.
Thank you. So the first case we're going to present today is going to focus on sequential transcatheter management of multivalve disease. So our patients A patient's an 88-year-old man with a past medical history of coronary artery disease, prior bypass surgery, ischemic cardiomyopathy with mildly reduced EF, prior atrial myxoma resection, a history of AV nodal ablation and a pacemaker, atrial fibrillation, hypothyroidism, and dyslipidemia. He was hospitalized with progressive exertional dyspnea, lower extremity edema, and abdominal bloating. And up till a month ago, he was doing fairly well and could walk a mile or so. He was on maximal tolerated doses for medical therapy for heart failure, and his exam was significant for distended neck veins and 2 to 3 plus pitting edema in his extremities and reduced breath sounds at the right lung base. So overall suggestive of a volume overloaded state. And his blood work was significant for an elevated creatinine, a high proBNP, and congestive hepatopathy. So moving forward to the imaging, so his transthoracic echo showed a mildly dilated left ventricle with an ejection fraction of 25 to 30% and at least moderate to severe mitral regurgitation. And this is the short axis of the at the level of the mitral valve, showing the location of the mitral jet being predominantly central. This is the short axis at the level of the aortic valve, showing thickened and calcified aortic valve leaflets with restricted leaflet motion. And the four-chamber view shows a large area of anteroapical akinesis with severe mitral regurgitation. This is the five-chamber view showing the calcified aortic valve leaflets. And he also had significant tricuspid regurgitation with severe pulmonary hypertension with estimated PS systolic pressures of 65 to 70 millimeter mercury. This was the Doppler profile of the aortic valve. So he had a peak peak velocity across the aortic valve of 2.4 meters per second, a mean gradient of 13, a peak gradient of 22. His DVI was 0.22, and his index stroke volume was 26, and the calculated valve area per the continuity equation was 0.7. So this was overall suggestive of low flow, low gradient severe aortic stenosis. So he was medically treated, diuresed aggressively with loss of around 20 pounds of body weight. His symptoms significantly improved, and prior to discharge home, we had performed a transesophageal echo. So this is the mid-esophageal view, four-chamber view, showing that showing the restricted movement of the posterior mitral leaflet and a severe central mitral regurgitation. The length of the posterior leaflet was 14 millimeters. So this is again, just showing the restricted movement of the posterior leaflet, so explain of the mitral valve. And this is the commissural view, showing commissure to commissure mitral regurgitation and large regurgitant jet. This is a Doppler profile through the pulmonary veins, showing pulmonic vein flow reversal, suggestive of severe mitral regurgitation. And this is showing the short axis of the aortic valve and the color Doppler through the mitral and the aortic, showing mild AI and severe MR. So he improved with diuresis and he was discharged home after 2 weeks of hospitalization. So he, of course, had multivalve disease with severe mitral regurgitation, low flow, low gradient, severe aortic stenosis, moderate to severe tricuspid regurgitation. And the question here was, like, what was the predominant contributor to his symptoms? Was it the MR or the aortic stenosis? And as a team, we felt that a dobutamine stress echo, which is the gold standard test to distinguish true severe from pseudo-severe aortic stenosis, we thought it could be of uncertain yield in the presence of severe mitral regurgitation. So we'll just pause here to have a hot team discussion on what's the next things to do.
All right, thank you so much, Tanush, for a great case presentation. To summarize, this is an older gentleman with a history of severe functional mitral regurgitation after optimization of medical therapy and a degree of low flow, low gradient aortic stenosis. Start with Dr. Goel. How would you approach this case of multivalvular heart disease?
Yeah, this is a very challenging case, not infrequent in our practice, where patients have aortic stenosis, mitral regurgitation, as well as tricuspid regurgitation. Obviously, the first thing to do in these patients is to medically, optimize them, diurese them, and then reevaluate, the degree of regurgitant lesions. In this case, I do agree that, dobutamine echo would have been ideal. However, the presence of such severe torrential mitral regurgitation would make the dobutamine and sort of a uncertain yield test. So this is a very challenging situation, and I think to further evaluate the aortic stenosis, it would be reasonable to obtain some further imaging, either in the form of a calcium scan or calcium score of the aortic valve or an MRI or both. Invasive measurements could be performed, but I suspect that the invasive measurements would demonstrate similar low gradients as demonstrated by the transthoracic echocardiogram.
Okay, thank you so much. Dr. Little, how would you evaluate somebody with severe mitral regurgitation and aortic valve stenosis? What would be your next choice of imaging modality, and what do you commonly see in these patients? Because as we know, when you have severe mitral regurgitation, you're going to have a low gradient aortic stenosis. So can you please walk us through your approach in the workup of these patients?
Yeah, thank you, Nadeen. And by and large, my approach would probably mirror that of Dr. Goel's comments. The challenging thing about this case is really trying to determine what's the dominant lesion. He's got TR, MR, AS, and they all influence each other. So if you think through, the aortic stenosis is low flow, and it's possibly low flow for three reasons. You've got low preload because of the volume lost to TR. You've got lost flow because of MR, and then you have a poor ventricle, with reduced ejection fraction. So you've got lots of reasons for low flow. And the challenge with the Doppler determination of AS severity is the valve is only going to open as much as it has to. And if there's very little forward flow, it's not going to open very much. So that's the principle of dobutamine, is to augment flow, allowing the valve to open up more if it can. And that's the test. Here you would likely just augment the MR with the dobutamine study. So I think a non-contrast CT for a valve calcium score could be very helpful. Clearly, if the valve calcium score is over 2,000, that would be very suggestive of significant aortic stenosis. But at the end of the day, the therapy is what can we offer this gentleman? He's 88 years old, significant comorbidities. Clearly, he'd be a high-risk surgical candidate. So we would want a therapy, a catheter-based therapy if one were available. Today, we have mitral interventions, we have aortic interventions. He likely would not qualify for any research study on the tricuspid valve. So the practical question is, mitral or aortic, and if so, if you could anatomically have either or both, which one do you do first? So in this scenario, that's really the challenge. Is the aortic stenosis making the mitral regurgitation worse, and therefore that would be the first choice for therapy, or is the mitral regurgitation so severe that we just can't accurately diagnose AS? So I think a CT would be helpful to know the valve calcium score at this point.
Okay, thank you so much, Dr. Little. Dr. Reardon, how would you approach this person who has a high surgical risk for open heart surgery and presenting with two seemingly significant valvular lesions?
Well, first of all, it's really not a surgical candidate. I mean, we can operate in this patient, we'll get him through surgery, but the ability of this patient to fully recover would be somewhat limited. And typically, if we had a high gradient AS and MR, we would do the downstream AS first. But as Steve mentioned, with this low gradient, it's really hard to figure out, is this really true AS? And so typically we would do exactly what you did: treat them medically first. If they remain with severe MR, then treating the MR first will then allow you to better evaluate the aortic stenosis. In surgery, we did dobutamines not only to find out if they had severe aortic stenosis, but because it was part of the prognosis. If you had a low flow, low gradient aortic stenosis and it was severe and it did not augment, that would raise your surgical risk about 3 times. If you had low flow, low gradient aortic stenosis and you did not augment, your risk would approach 30%. It doesn't seem to be the same in TAVR, but in surgery, we used it not just to find if it was severe, but to look at your surgical prognosis.
Thank you. Dr. Kleiman, how would you approach this patient if it's determined that both lesions are severe? And what discussion would you have with the patient regarding the sequence of interventions that might be planned?
Well, that's a loaded question. First thing is, if Dr. Reardon is not eager to operate on this patient, and you have determined that both lesions are severe, then I'd work with the maxim that surgeons always use, which is outflow first. So I'd perform a TAVR. That at least gives you a little bit of, the concern is always, well, not the concern, but the hope is always that mitral regurgitation will get better if you reduce aortic impedance. That usually doesn't happen, but what it does do is gives you a little more margin of safety if you have blood pressure swings during mitral valve repair. So if you make the determination that the aortic valve is severe, that's what I go for first. But, it brings up another issue, and that is we frequently see these patients, and we operate in a very broad zone of uncertainty. And sometimes we just have to make decisions and proceed along those lines.
Thank you, Dr. Kleiman. Tanush, if you want to let us know what happened with the patient.
Great, so thanks for the comments. And so just to pause, for the latest version of the guidelines, if as the panel discussed, if we did determine that both the lesions were significant, the guidelines would suggest for an inoperable patient to for them to have a TAVR first, followed by edge-to-edge repair if anatomically feasible, and if MR were to remain severe after correcting the outflow, that is the aortic stenosis. So we obtained a calcium score on this patient, and the calcium score was 1360, so which is suggestive of more moderate than severe aortic stenosis. We also obtained a secondary assessment by virtue of a cardiac MRI, and a planimeter valve area on the cardiac MRI was 1.5 square centimeters. So the AS overall here was moderate by calcium score and cardiac MRI, and the mitral regurgitation, of course, was clearly severe, and his anatomy was suitable for edge-to-edge repair. He was deemed prohibitive risk for a double valve surgery with a predicted STS predicted risk of mortality of 11.5%. He was seen by heart failure, referred to the heart failure clinic. He continued to remain symptomatic after optimization of guideline-directed medical therapy for a period of several weeks, and the severity of his valvular lesions remained unchanged on repeat echocardiography. So therefore, he was referred to us for edge-to-edge repair, and we decided to perform the procedure with hemodynamics and invasive aortic valve gradient assessments before and after the MitraClip. So these were his hemodynamic measurements before the MitraClip procedure. So even after weeks of optimization, he was very decompensated in a way. His mean RA pressure was 28. He had severe pulmonary hypertension with a mean PA pressure of 55 and a LA pressure of 30 with V waves of 66 millimeter mercury. And we also did a pullback across the aortic valve, and his peak gradients AO2 LV were 7 millimeters mercury. So we really did think this was not a severe AS at this point. So this is the MitraClip procedure. This is we used an NTR device. So this is positioned bridging the A2 and P2 leaflets. And this is in the grasping view with the leaflet arms open and the leaflets falling on the open arms, and then we retract the leaflets. You can nicely see here the leaflets making contact with the open arms, and here we have dropped the grippers and locked the clip, and we can see that the MR severity is really reduced to mild here. This is the mean mitral gradient post locking of the clip, and the gradient's 3. And this is a beautiful example of pulmonic vein spectral Doppler profile before and after the clip. So you can see the reversal of the pulmonary vein flow, and now in the right hand panel you can see an upright S wave. So this is the final result post the MitraClip. His MR severity is reduced to mild, and this is one of the most dramatic hemodynamic changes I've seen before and after a clip. So you can see the right atrial pressure coming down to 5 from 28, mean PA pressure coming down to 29 from 55, and the LA pressure coming down from to 9 compared to 30 before, and the V wave came down from 66 to 17, and this is in a different scale, so it doesn't look that dramatic. As expected, there was probably some increase in forward flow, and the peak-to-peak LVAO gradient was 21 after the MitraClip procedure. And he did have a iatrogenic ASD with a bidirectional flow on TEE, and in the setting of pre-existing severe pulmonary hypertension, we went ahead and closed the hole with a 10 millimeter ASO device. So we can pause here maybe for a discussion on the role of closure for an iatrogenic ASD.
Yeah, no, this is a great result with the MitraClip, as demonstrated by the hemodynamics as well as echo evidence of significant reduction from very severe or torrential mitral regurgitation to trace to mild regurgitation with an acceptable gradient. This sort of confirmed the thought that this primary or the predominant lesion in this case was the mitral regurgitation, and after adequate imaging and multimodality imaging, this decision was made to move forward with proceeding with edge-to-edge repair. In vast majority of cases that we do transcatheter edge-to-edge repair, we do not close the iatrogenic ASD. Because at the end the shunt is left to right in vast majority of patients, and by 9 to 12 months again a vast majority of these iatrogenic ASDs will close spontaneously. In a small percentage of patients, when there is high or elevated right-sided pressures in the presence of TR or significant pulmonary hypertension, there is a risk of bidirectional or right to left shunting and hypoxia. So these are the cases where we choose to close the iatrogenic ASD after the MitraClip procedure. And this patient met some of those criteria, hence we decided to close. So I think in our experience, the rates of closure of iatrogenic ASD is less than 10% of all the edge-to-edge repair cases.
Great, thank you. So this was his transthoracic echo after the procedure. So the MR severity is really reduced to mild, and the TR severity on the right-hand panel also reduced from moderate to severe to at baseline to mild to moderate. And so this is the aortic valve Doppler profile after the MitraClip. So there was an increase in LVOT VTI, which was 10 centimeters before, so to 13 centimeters now, but overall the indices were still suggestive of severe AS with a DVI of 0.19, and the mean gradient now was 24. The patient improved symptomatically, and he was discharged home the next day after the clip. We saw him in the valve clinic 1 month after his clip procedures. His symptoms improved dramatically from class 3 to class 2, and his lower extremity edema and orthopnea had resolved. There was a decrease in diuretic usage, and so at this point we decided to perform the butyramine stress echo to distinguish pseudo-severe from severe aortic stenosis. The quad panel demonstrates the contractility of the LV from at baseline to all the way to the bottom right hand corner at 20 mics of butyramine. So we get a 25% increase in stroke volume, and his transvalvular peak velocity was 4.1 meters per second at the peak butyramine dose, with a mean gradient of 45 and with an unchanged aortic valve area. So this essentially confirms severe aortic stenosis. It also raises into question the utility of the calcium score, which was suggestive of moderate AS. So at this point, we decided to proceed with TAVR, and this was the CT demonstrating his aortic valve anatomy. So the perimeter of the valve was around 78 millimeters with the area of 466. These are the angulations. He had sinuses approximately 29 millimeters, good coronary heights, and suitable transfemoral anatomy. This is the TAVR procedure. So this was we decided to deploy. He was sized for a 29 millimeter evolute valve, and the deployment's done in the cusp, or using the cusp overlap technique, which is our traditional mode of performing self-expanding valve TAVR for the last year or so. And this is his echo after the TAVR. So beautiful result with minimal aortic regurgitation, and you can see the MR severity is really mild. His RV function has now normalized. His DVI on the aortic valve was 0.7, and the TR severity at the end was moderate. And this is just showing a recent manuscript of showing the management of 100 patients with significant MR. This is post-TAVR compared to, and we can see that if patients undergo edge-to-edge repair, they really do have sustained improvements in their New York Heart Association functional class, and they have sustained improvements in MR grade up to a year. And if these patients undergoing MR correction by edge-to-edge repair were compared to medically managed patients with significant MR post-TAVR, there is a suggestion of a mortality benefit as well. So our patient was discharged home day 1 post-TAVR, and he's now been followed up, I think, around 6 months after his valve procedure, and he can now, he's back at his baseline. He can walk up to a mile without symptoms, and this 80-year-old gentleman really says he now feels like a 20-year-old. So,
great. Fantastic. That's a great case presentation, Tanush, and it was very gratifying to see this elderly gentleman return to his baseline functional status with 2 transcatheter valve therapies that have evolved over the last decade. And I think this case highlights the importance of multimodality imaging in teasing out which is the predominant lesion that needs to be treated in patients with multivalvular disease. As pointed out by Dr. Kleiman and Dr. Reardon and others, usually when patients have severe aortic stenosis and severe mitral regurgitation, the initial valve intervention of choice is transcatheter aortic valve replacement, followed by reevaluation of MR. When looking at the TAVR data, we know that around 10 to 15% of patients undergoing TAVR have severe mitral regurgitation, and severe mitral regurgitation is a marker of adverse or poor prognosis after TAVR. In about 50% of the cases after TAVR, the mitral regurgitation can improve, especially those who have functional mitral regurgitation, whereas it's less likely to improve in patients who have more degenerative mitral regurgitation. And so that's why it's important to keep an eye on their mitral regurgitation after TAVR. And if they continue to have significant mitral regurgitation, and if their anatomy is suitable, they may be appropriate candidates for edge-to-edge repair. In this case, the sequence was reversed. As discussed, the valve gradient was very low, and the calcium score and the MRI both suggested less than severe aortic stenosis. But eventually, the patient did require transcatheter aortic valve replacement, which was successfully performed with a good clinical outcome.
I'll tell you, Sachin, I would have to comment, though, that it just shows how confusing it is. The calcium score really suggests severe aortic stenosis in a woman. Anything over 1,200 in a woman is severe, 2,000 in a man. But then the MR is moderate. So it just shows you, how difficult these things can be to ferret out. And going through the entire, workup was really important in this particular patient.
Absolutely. Thank you.
Thank you so much. Dr. Payam Pournazari will be presenting the second case.
Good morning. Thank you for joining us. So the second case that I will be presenting for our structural heart disease interventions is a case of biprosthetic valve failure. So our case is a 43-year-old female that presented with worsening peripheral edema and shortness of breath. She has extensive past medical history, ischemic cardiomyopathy with CABG, with Lima to LAD and vein graft to PDA, which was complicated by graft occlusion and PCI. And then she had an episode of VF arrest post-op, which required ICD implantation. She had severe tricuspid regurgitation, which was diagnosed pre-CABG, and the initial plan was to have the leaflet and the valve repaired. However, the leaflets were very restricted and frozen, and so she subsequently underwent a tricuspid valve replacement with a 25 millimeter Edwards Perimount Magna-Ease. She's type 1 diabetic since age 11 on insulin therapy, and she is a failed pancreatic transplant. End-stage renal disease and a failed renal transplant, currently on hemodialysis. Also, hypertension, pulmonary hypertension, normocytic anemia, hypothyroidism, depression, anxiety, gout, and there was no history of illicit drug use, anorexic agents, or ergotamine use. Her medications at the time of presentation was aspirin, clopidogrel, warfarin, metoprolol, atorvastatin, insulin, sertraline, and levothyroxine. Initial examination was unremarkable for the vitals, but she had neck vein distensions, and she had +2 peripheral edema. Her BNP was elevated at 1854. Her creatinine and BUN was elevated at baseline for her. She's a dialysis patient, and her blood cultures were negative. This is the initial echocardiogram before she had her CABG, which showed normal LV and RV systolic function, and severe tricuspid regurgitation with frozen leaflets. After the tricuspid valve replacement, this is the follow-up echocardiogram post-CABG, which showed normal biventricular function with little evidence of tricuspid regurgitation and a well-functioning prosthetic valve. As I stated, her course was complicated by graft occlusion and VF arrest. So this is the follow-up echo with a severe LV dysfunction and ICD implantation. And her tricuspid valve, the bioprosthetic valve, showed mild regurgitation with increased gradient across the valve of 5 millimeters of mercury at a heart rate of 70. Which brings us to the echocardiogram at the time of presentation, when she presented with the symptoms of right-sided heart failure. Just going to make sure this plays well. Sorry, just gonna, I think it doesn't play well here, so.
So, just to summarize, this is a 43-year-old lady who has a very complex medical history, type 1 diabetic with failed kidney transplant, failed pancreatic transplant in the past, who's now on dialysis. About a year and a half ago, she had coronary artery bypass surgery along with tricuspid valve replacement. Post-operatively, her course at that time was complicated by a VF arrest secondary to graft occlusion. She underwent PCI, and then subsequently an ICD was implanted for secondary prevention of sudden cardiac death. And then over the course of the ensuing 6 to 12 months, she progressively developed worsening symptoms of dyspnea, lower extremity edema, abdominal distension, essentially right heart failure symptoms. And that brings us to the echocardiogram at the time of this presentation.
Thank you.
Go ahead.
So this is the echocardiogram that showed moderate to severe LV dysfunction post ICD implantation, and mild tricuspid regurgitation and increased gradient across the tricuspid valve with a gradient of 5 millimeters of mercury with a heart rate of 70. So this is the echocardiogram when she presented with symptoms of right-sided heart failure. Overall, there was improvement in the LV systolic function with mild to moderate LV systolic dysfunction. RV function was preserved, and now she has evidence of moderate to severe tricuspid regurgitation, which was new and developed in the past 4 months since she had the valve replaced. So the plan was made to perform a TEE to assess the mechanism and severity of tricuspid regurgitation and to see whether there is any lead impingement of the leaflets. As you can see in the middle image, the leaflets are not coapting well, and the lead is not really interfering with the leaflet mobility. However, the main clue came with the 3D imaging. We did the 3D imaging with TEE, and as you can see on the left-sided image, there is no coaptation of the leaflets at all. All the leaflets are frozen, leading to a very large non-coaptation gap and wide open TR. So I would like to pause here and ask our panel in terms of the management options for this patient.
All right, thank you so much, Payam. I'm glad you're presenting a case of tricuspid valve. This used to be the forgotten valve, but now it's one of the valves is getting a lot of attention. Impressive case of prosthetic valve dysfunction with frozen leaflets and significant tricuspid regurgitation and the presence of an ICD lead. Dr. Little, what are the challenges associated with tricuspid valve evaluation by imaging in the presence of a pacemaker lead that could cause a lot of acoustic shadowing? How would you approach this patient to determine the etiology of the tricuspid regurgitation?
Thanks, Nadeen. I mean, this is clearly a tough one. Tricuspid valve, as we know, can be tough to image most of the time simply because of its anterior position in the heart. So that can make it challenging by transthoracic, and by TEE, you may not have a good esophageal orientation in relation to the tricuspid valve, so that can be tough. This case is compounded by the prosthetic artifact by the valve itself now, with prosthetic material, and the AICD lead, which can be quite sizable. So there's lots in this case to make it challenging. Despite that, the imaging, I think, particularly the 3D imaging you showed at the end, is very clear that it's not simply a matter of lead impingement of one or conceivably more of the prosthetic leaflets. They're really sort of shriveled and immobile, and there's been a biologic process of some kind that has affected these valves, these leaflets. So I think in this case it's clear what the problem is. The treatment options are really challenging. I think we'll let the rest of the panel talk about what those options are and what we ended up doing. But It can be tough. This is tough, this case, clearly to be sick, relatively young lady. But I think the imaging already displayed is pretty diagnostic, so we know what's going on.
Thank you so much. Dr. Kleiman, what transcatheter interventions would you evaluate this patient for, knowing that they're at a high surgical risk?
Well, you'd obviously want to valve in valve in the tricuspid position, which actually is reasonably easy from a technical standpoint. The issues here are you have a patient who's fairly ill, and you have a defibrillator to deal with. Now, one of the questions is, this defibrillator was implanted in the acute post-op setting when there's likely graft occlusion or ischemia. That seems to have settled since that time. How badly is the defibrillator, or is the defibrillator still needed? And what other surgical approaches are there, or other approaches to implant a defibrillator? So that's a discussion with EP before you make your next step.
Thank you. Dr. Reardon, this patient already had surgery. What discussion would you have with this patient about surgical options versus transcatheter options in this situation?
Well, first of all, the tricuspid valve really is not the forgotten valve, Nadeen. We just try to ignore it. If we operate on your tricuspid valve in your first surgery, there's really no risk. But when they've come back after a failed previous surgery, they tend to be a high risk because of how sick the patients are, not because of how technically difficult it is. So, can we operate on this lady? Yes, we can, but it would be a high surgical risk procedure. And certainly we would look very carefully for transcatheter approaches. As Neal has said, doing a transcatheter tricuspid valve in valve is easy. The complicating factor is that you have this lead there, and you don't want to trap that lead, by putting a balloon expandable valve and then trapping that lead between that valve and the original surgical valve. And so again, my question as a surgeon would be the same thing: is, do you really need that defibrillator? It was put in when a graft occluded, and it probably is no longer needed, and it can probably come out. And then if you really need it, we can always go back in and put one in the subcostal zone if you don't want to cross the valve again. But I think, my approach is to try very hard to avoid surgery. We can operate, but it's not a low risk operation.
Thank you.
There are a variety of EP options as well, leadless defibrillators, coronary sinus. So that's a discussion you've got to have beforehand.
Thank you. Dr. Goel.
No, I agree with everything that's been said thus far by the panelists. And the challenge here is really, what do you do with this defibrillator lead? Obviously, a careful discussion was held with electrophysiology regarding the options. Nobody wants to entrap the lead. The options would be a coronary sinus lead, or a leadless, leadless device, or even possibly epicardial lead placement. So these are the discussions that I would have with electrophysiology in this setting. If I were to do a valve-in-valve tricuspid valve replacement, I would try to avoid a lead through the second valve as much as possible. I don't clearly understand the mechanism of early failure in this case. This is a young lady with a sort of a, not a great protoplasm to begin with type 1 diabetes, renal failure, failed transplants, and now an end-stage renal disease. I'd be worried about, failure of the transcatheter valve also. And if we can avoid a lead through the transcatheter valve, that would be the best case scenario.
Okay, this is a great case of a multidisciplinary discussion when it comes to these complex cases. So discussion with cardiology, surgery, imaging, and in this case we also had a detailed discussion with the AP physicians, and maybe Payam can shed light on that discussion.
Thank you. Yes, so as clearly stated, this was a case of prosthetic valve failure with unclear etiology. After careful investigations and a lot of discussions, we couldn't come up with a diagnosis as why this valve failed so quickly after the surgical implantation. And the treatment options were discussed with the heart valve team. There were 3 approaches: conservative management, redo TVR, which a patient was deemed to be very high risk given her anatomy, dependence on the LAD graft, and the high risk nature of the operation. And then the last option was a transcatheter valve-in-valve option. We discussed her presentation with our colleagues in electrophysiology. They felt that the patient still needs the defibrillator, despite the LV function being improved in the mild to moderate category because of the arrhythmic events that she had in the past. So plan was to proceed with a valve-in-valve option. Before we go through the procedure, this is the new algorithm that proposed by the 2021 valve guidelines that was published just recently with bioprosthetic valve failure. In these patients with high or prohibitive surgical risk, they are with bioprosthetic valve regurgitation. A transcatheter valve-in-valve option is a 2A recommendation. Patient underwent a CT TTVR planning to assess the leaflets and overall a better surgical and procedural planning. And then we use the 3Mensio software to assess the valve for procedural planning and sizing of the transcatheter valve-in-valve. The 3Mensio suggested that a 26 millimeter valve can be implanted without any issues, and that was what planned. And then we had a successful transcatheter valve-in-valve implantation with a 26 millimeter Sapien S3. ICD lead was removed, and post-procedure subcutaneous ICD lead was placed by our colleagues in electrophysiology. These are the live fluoro images from the implantation. On the left side image, you can see that the guide wire is first sent to the RVOT and then bring to the RV apex. In the middle image, there is the expansion of the Sapien 3 valve, and on the right side image, it was the placement of the subcutaneous ICD lead. These are the intra-procedure TE images. The top row shows the tricuspid bioprosthesis valve. After the ICD lead is removed, you can see the frozen leaflets with wide open TR. The bottom row shows the valve-in-valve implantation of the Sapien 3 with good results and no tricuspid regurgitation. Post-procedure TTE showed that both RV and LV are mild to moderately depressed. The valve-in-valve bioprosthesis is functioning well, with no tricuspid regurgitation and a mean gradient of 2.6 at a heart rate of 69. Patient felt much improved and was discharged home 2 days post-procedure. I'm going to review some of the literatures for bioprosthesis valve failure and valve-in-valve data for tricuspid. So the bioprosthesis valve failure diagnosis is based mostly on echocardiogram, special TE and 3D. The etiology, endocarditis, thrombosis, and structural failure are the top three. Most of the data is from the aortic valve registries and databases. And there is a new proposed mechanism for early failure with this metabolic profile in patients with high inflammatory state, especially end-stage renal disease and diabetes. The VIVID registry looked at the transcatheter valve-in-valve data for tricuspid, looking at 152 patients. with high success rate and low 30-day mortality and good relief of symptoms. In this 152 patients, age, acute illness, NYHA class, and end-stage renal disease or acute kidney injury were predictors of poor outcomes. And they also showed that both age and NYHA class 4 are predictors of mortality and tricuspid reinterventions. Thank you.
Perfect. Thank you. Thank you so much, Payam, for this case presentation. Dr. Goel, any final thoughts?
Yeah, no, this was a very challenging case, as you all saw. The tricuspid valve is of great interest in today's day and age. The valve-in-valve is one aspect, but also for native tricuspid regurgitation, there are increasing number of options, and we are here at Houston Methodist are participating in the randomized TriLuminate study, which is evaluating the safety and efficacy of a dedicated tricuspid clipping system compared to medical therapy in patients with native severe mitral regurgitation. In addition to clip procedure for tricuspid regurgitation, there are other options in the form of transcatheter tricuspid valve replacement, again for native tricuspid regurgitation, which are in the pipeline, and stay tuned.
Thank you so much. Dr. Tanush Gupta is going to be presenting our last case for this morning.
Thank you. And so now moving on from tricuspid prosthesis dysfunction to a patient who had biprosthetic mitral valve dysfunction. So this was an 82-year-old elderly woman with a medical history of hypertension, prior stroke, atrial fibrillation, and non-obstructive coronary disease. So in 5 years prior to her presentation, she had undergone a mitral valve replacement with a 25 millimeter Carpentier Edwards Paramount Magna Ease valve, and she was hospitalized with congestive heart failure with class 3 New York Heart Association class 3 symptoms. She had severe biprosthetic mitral valve stenosis with a mean gradient of 20, moderate to severe mitral regurgitation, pulmonary hypertension, and with an estimated RV systolic pressures of 55 to 60 millimeters mercury, and she was high risk for redo MVR with a STS predicted risk of mortality of 9.5%. So these are the transesophageal echo images. On the left-hand panel, we can see that there is at least 2 plus mitral regurgitation, and on the right-hand panel, we see the Doppler profile through the mitral valve with the mean gradient of 16, suggestive of severe biprosthetic mitral stenosis. This is the 3D of the prosthetic mitral valve. So on the left-hand panel, we see the thickened mitral valve leaflets with the restricted opening, and on the right hand panel in systole we can see the mitral regurgitation jet, and in diastole we can see flow acceleration through the mitral valve, suggestive of significant stenosis. So this was her gated cardiac CT. So this is akin to this is analogous to the 3-chamber view on the echo, and so here we can see on the left hand panel a restricted opening of the prosthetic mitral leaflets, and we can also see that the anterior leaflets causing some degree of obstruction of the LVOT. And on the right hand panel we see a CT which at the base of the heart cut at the level of the tip of the prosthetic leaflets, showing restricted motion, suggestive of stenosis. And this was the CT assessment of the neo-LVOT with a virtual heart valve in place. So she was the 25 Paramount, the 25 Magna was size 4 to 26 sapien S3 with the valve and valve for a valve and valve implant. So from the outflow of the valve to the interventricular septum, the distance, the linear distance was 3.1 millimeter. And with a transcatheter heart valve in place, the neo-LVOT was 180 square millimeter with at the 30% systolic phase. So we can pause here for a discussion as to what would be the approaches here.
All right, thank you, Tanush. So we know that LVOT obstruction is the Achilles heel of TMVR. Dr. Little, what are some of the risk factors for the development of LVOT obstruction? How would you evaluate for that, even in patients with native mitral valves?
Yeah, thanks, Nadeen. So briefly, I mean, there's patient anatomic features, small ventricles, thick septum, and probably one of the most important is the aortic mitral angle. The closer that angle is to 90 degrees, the more likely you are to have obstruction with a new device, the LVOT. And then I guess to a lesser extent, there are some technical factors. What's the valve in the mitral position? Is it bovine pericardium? Is it porcine? Those have different impacts on the risk of LVOT obstruction. And probably to even a lesser degree is how deep you implant the new valve within that structure. So there's lots of things to consider, both patient risks and procedural risks. But CT is generally the tool we use. Obviously, echo gives you a sense of what's happening, but in terms of the aortic mitral angle, and as you just demonstrated, the application of a commercial software to do the prediction of Neal LVOT, that's fairly standard today.
Thank you. Dr. Kleiman, in a patient with a high risk for LVOT obstruction by TMVR, what are the possible interventional procedures that can be utilized to decrease that significant risk?
Well, I anticipated that question. And Tanush, we're almost out of time, so I want to keep it really brief so we can present the case. Two options are electrocautery to lacerate the anterior leaflet so it doesn't obstruct the LVOT, or septal reduction with an alcohol technique. With an alcohol technique, which really wouldn't be applicable in this case because the septum's not very thick, and you might end up with damage and a VSD that would make you regret what you did. So here it's electrocautery or nothing.
Okay. Tanush?
The team discussion was that she was a high to prohibitive surgical risk, and as Dr. Kleiman mentioned, that septal ablation was thought to be of less benefit because of the thickness of the basal septum. So we decided to proceed with this case with a Lampoon procedure, which is the intentional laceration of the anterior mitral leaflet to assist the TMVR procedure. So brief illustration of the two approaches to Lampoon. So the classical retrograde Lampoon approach is where we are positioning two retrograde guides to the aortic valve, and one is positioned against the base of the anterior mitral leaflet, and then we take an electrified guide wire to traverse that leaflet, which is then snared to create an arterial rail, and then apply electrocautery to lacerate that leaflet. And that's a technically more challenging procedure because it involves the traversal of the leaflet. A new iteration of this procedure is the tip to base Lampoon, which can be utilized in patients with either a prosthetic ring or a bioprosthetic mitral valve, because the mitral annulus is protected by the surgical ring or the sewing ring, and this cannot be applied in patients with native mitral valves because there is risk of injury to the aortomitral curtain when you're pulling negative tension on your guides, and that can lead to catastrophic consequences such as torrential AI and whatnot. So, both the techniques, this was the recent feasibility showed that tip to base Lampoon is 100% effective in this selected 20 patients, and all patients survive to discharge. The key steps of the procedure are illustrated here. So, a steerable guide catheter is positioned in the left atrium through which we pass a balloon tip catheter into the left ventricle, which is then directed to come out of the aortic valve, through which an stato guide wire is advanced, snared in the ascending aorta. We create a veno-arterial rail, and then a denuded stato wire is advanced through the venous side, and this is in an insulated microcatheter called the piggyback catheter, and then a flying V is created, and negative tensions applied to lacerate the leaflet. So this is the fluoroscopy from our case, and on the right hand panel, this LAO caudal projection is key to show that the guides are positioned, the flying V is positioned at the middle of the leaflet and between the two stent posts, so that you get the maximal benefit from your laceration. And this is the 3D TE when the cautery is being applied. So you see these the bubbles suggestive of the electrocautery has been performed, and just after that we see this flailing appearance of the mitral valve and severe iatrogenic regurgitation, also suggesting that laceration successfully been performed. And then we proceed with the standard transseptal valve and valve TMVR with the 26S3, which was filled with the nominal +1 cc of volume. So this is the valve going up, this went pretty uneventfully. And this is the left ventriculogram post TMVR showing actually no mitral regurgitation and no obstruction to LVOT flow. The post TMVR transesophageal echo showing normally functioning bioprosthetic leaflets, a mean gradient of 2. And this is the final LVOT anaortic valve Doppler profile. So on the left-hand panel is the continuous wave Doppler showing a peak velocity of less than 1.5, and the LVOT velocity was again 1.2. So our patient's now out over a year after her procedure, and we recently reviewed her 1-year echo. She has no residual mitral regurgitation, a mean gradient of 4, and LVOT gradient of 8.6.
Great. So this is a great case, again demonstrating the utility of surgery techniques which have evolved over the last few years in not just the mitral space but the aortic space as well. And we have had experience with the Lampoon procedure as well as the Basilica procedure. These are electrosurgical techniques to lacerate leaflets, either mitral or aortic. In this case, to reduce the risk of LVOT obstruction from mitral valves, and in the cases of aortic valve during TAVR, to reduce the risk of coronary obstruction. So these are revolutionary techniques which have evolved in the last 5 years, and more and more evidence is being gathered in the safety and efficacy of these techniques. And most recently, a couple of publications, a couple of registry data were presented at CRT. Demonstrating safety and efficacy of this technique. And these techniques have allowed us to perform these procedures and reduce the risk of complications such as LVOT obstruction or coronary obstruction in cases of TAVR.
Thank you so much.
I think there is one question. In the interest of time, we can just quickly address this. The question is, in case of association of AS and MR, could the relative degree of LV hypertrophy and LV dilatation and the LV geometry be of guidance to predict better the chances of potential regression of MR after TAVR? That's a good question. What we've learned from the COAPT study is obviously the bigger your LV, the worse your LV dysfunction. These patients were excluded, but some of these patients were included in some of the other trials of edge-to-edge repair, and they did not do as well as patients did in the COAPT trial. So what we know so far is patients who have big dilated LVs, more than 7 centimeters systolic dimension, or LV ejection fraction less than 20%, those patients are unlikely to benefit from edge-to-edge repair, for mitral regurgitation, and those should perhaps be evaluated for advanced heart failure options such as LVAD or transplant.
Thank you so much. Dr. Goel, I don't think we have any more questions. We want to thank you all for joining us today, thank our presenters and our panelists, and we will see you back next week. Have a good one.
Thank you all. Thanks.